So, go ahead, ma'am.
Good afternoon, everyone. My name is Dr. Sneha Balki. I am IVF consultant at Oasis Pune Center. So, today we are going to discuss an important topic, and the topic for today is how can we go an extra mile to get an optimum result in poor ovarian reserve. So, lots of terms have been used in this topic. So, let's break it down and make it simpler to understand. So, what does it mean by ovarian reserve, first of all? So, let's understand the basics. Ovarian reserve is the capacity of the ovaries to produce the eggs. So, what is the number of eggs that is usable or that can be used for reproductive function in the ovaries? So ovarian reserve is something that is we are born with as females, and we get by birth, by default we get a few set of eggs on both the ovaries, which during the due course of our lives we keep on depleting. So what is the ovarian reserve basically is at any given point of time the number of eggs that are remaining for reproductive function is termed as the ovarian reserve. Now, how do we assess the ovarian reserve? There are a few tests, out of which the major tests that are being used commonly in practice or that you commonly come across as patients who are seeking fertility treatments are AMH, which is a hormone test, can be done with normal blood test, and there is one specific test which is known as antral follicle count, which is the number of eggs that is seen on second or third day of a period cycle, which is counted by sonography. So these two tests are basically the governing factors which guide us regarding the ovarian reserve. So ovarian reserve is something that keeps on declining, and the best criteria which governs what is the ovarian reserve is the age of the female. So uh, a simple dictum would be that a younger the female, the better her antral follicle count would be, and her AMH would be normal or near normal. So, what is a normal AMH and a normal antral follicle count? So, AMH between 2 to 4 nanograms per liter is termed as normal. So, any value between 2 or 4 is considered to be normal. When the AMH is beyond 4, we term that lady as she might be PCOD or a hyper responder. When the AMH falls with age and it goes below 2, but it is more than 1, it falls under low AMH, and the most difficult is when the AMH falls below 1, we term it as very low AMH. So these are few terminologies. In here, low AMH is quantified by antral follicle count when the normal antral follicle count of 8 to 12 eggs on both sides is not met, and the antral follicle count on second or third day of your periods is somewhere below 4 to 5 follicles on both sides, on both the ovaries. So, this is something which is in general, which would dictate what is the ovarian reserve. Now, what happens is, although age is the determining criteria for your antral follicle or your AMH, which is your ovarian reserve, sometimes even in younger age, what happens is the ovarian reserve has declined a lot, which we term as premature ovarian insufficiency or premature ovarian failure. So, this is something which, as clinicians, we might not expect in that particular age in a lady, but even so, the ovarian reserve is quite low in these women, and they seek treatment for fertility, where we use this ovarian reserve as a guide for planning their fertility treatment. So the basic difference, the basic importance of ovarian reserve is that it helps us in planning the fertility treatment in accordance, like in conjunction with other factors of consideration also pertaining to that particular couple. So, what are the factors that we generally consider before we plan the treatment for a couple? So the treatment depends basically on the age of the female, age of the woman, the duration of infertility or the duration of marriage that they have been trying to conceive, if there is any associated male factor which is contributing to the fertility treatment, and what is the ovarian reserve at present. Along with this, some other factors like whether there are any tubal pathologies associated which might get in the way of the couple conceiving naturally or with basic treatments like ovulation induction and IUI. So all these factors might be different for each and every couple. So the treatment approach is subjective and it's not objectively determined every for every couple. So it differs for each and every couple. Now, the most important determining factor of your reproductive outcome or your treatment is your ovarian reserve. So the ovarian reserve is something that primarily decides what would be the plan of treatment. So whenever the ovarian reserve is bit on the lower side, it gives us an indication that the treatment should be on a faster pace and there should not be any wastage of time between start of treatment and conception. So this ovarian reserve is also another important indicator when we as clinicians plan the treatment in accordance with what is the desired objective. Like if a lady is there who doesn't plan on conceiving soon or she is unmarried, but she is planning to conceive later in her life, where the ovarian reserve might not be as good as it is right now. So ovarian stimulation with oocyte freezing is something which also can be offered when we are anticipating that a poor ovarian reserve might be encountered later when the lady is planning to conceive. So, what are the things that we can do for poor ovarian reserve? So, when we consider all these factors, then the best treatment for a poor ovarian reserve is definitely IVF, because the best success rate is going to be produced only when we get a higher number and along with that a better quality of oocytes. So, however, if uh, the age of the female is less, like the female is younger than 30 years old and her duration of marriage is not much and they have never tried any other form of treatment for reproduction, then basic treatments can be offered as a initial treatment. So basic treatments like ovulation induction and timed intercourse or tubal testing associated with IUI. So such basic treatments can also be offered when we encounter a low AMH. However, if the age of the lady is higher or she is more than 35 years old, with less duration of infertility, we might have to speed up the process where an IUI would be the starting treatment provided the tubes are patent, and if not so, then we should move on to IVF where the tubes are bypassed and we get a better yield of oocytes which contribute to a higher success rate, specifically when the AMH is less or the ovarian reserve is low. But even here, what is the thing that we should do as clinicians and as patients to optimize the success rate or optimize the results, even if the AMH or ovarian reserve is lower? So, as patients, what are the things that you should be aware of? So, the earlier you conceive, the better chances of you conceiving sooner and conceiving a healthier child are definitely there. But because of whatever reasons like education, career, or societal reasons, if pregnancy is being delayed, oocyte freezing is one thing that can be considered. However, if for some reason that hasn't been possible for you, then definitely, if the pregnancy is not achieved with some basic treatments, we move on to IVF. Even in IVF, there are a few things that we need to do to get the optimum results. Let's start with diet and lifestyle modifications. So, there is definitely a role of good antioxidant, good protein, and good micronutrients which you take in your diet routinely, and it definitely has an indirect effect on the quality of your eggs. So number of eggs is something that is finite, or that is what we have in limited quantity, but the quality of it, even if it is in lesser number, if the quality is of better value, then definitely we can get a better result. So quality is what matters, and quality is something that we can manipulate to some extent by taking these nutritional supplements and modifying your diet and lifestyle to certain extent, whatever is feasible. After this, if there are a few history of previous failed IVF or previous low response, in such situations, we tailor the protocol of stimulations pertaining to what is required for that particular female or particular woman. Like the conventional protocols for ovarian stimulation is basically an antagonist protocol, which has been used conventionally for most of the women who undergo IVF. But here, the main focus, I would rather say, is the rather than the quality of regard. There are a few other protocols which can be definitely used, such as agonist protocol, microdose flare protocols, which tend to focus more on getting a better quality oocyte, specifically when there is a lesser ovarian reserve rather than getting higher number of oocytes. So this is something that should be tailored according to the specific woman undergoing the treatment. If in spite of this, there is a poor ovarian response, or the quality or the number of eggs that has been received through the IVF process is still substandard or suboptimal. In that scenario, there are some newer techniques that can be definitely employed to achieve a better response. So, ovarian needling is something that gives a physical stimulus to the ovaries. So, once we prick the needles, the blood supply towards the ovaries increases in order to heal that wound. As a byproduct, what we get is more recruitment of antral follicles for that particular cycle, which can then be stimulated by gonadotropins, and thus these eggs, a higher number of eggs, is available for stimulation in that cycle. So, another method which can be used is ovarian PRP installation. So, PRP is platelet rich plasma, which is a concoction of activated platelets and plasma drawn out of the blood of the same woman or the same patient, in which we just remove the RBCs or the red blood cells through some centrifugation process. And this concoction that we isolate is then injected in the ovarian stroma, which in turn the platelet activating factors and the inflammatory mediators that are injected in a concentrated manner in the ovarian stroma thereby stimulates the recruitment of antral follicles in the next cycle. So, this is how ovarian PRP works. And after an ovarian PRP, the stimulation or the response from the ovary is anticipated to be better, to yield a better oocyte collection in the subsequent stimulation cycles. So there are also few experimental, I might say, experimental treatments like ovarian stem cell therapy also. So the similar way that we do ovarian PRP installation, there is an instrumental treatment also which is ongoing, in which the stem cells derived from the bone marrow are processed and injected inside the ovarian stroma, which acts under the same principle, and there is a higher recruitment of antral follicles which can be then stimulated in the subsequent cycles. So this is some extra therapies that might be necessary in patients who are having or who are facing a poor ovarian reserve. Along with this, there are some things that can be done on the embryology end also. So once the stimulation, once the pickup of eggs is done, the received eggs are then handed over to the embryologist, who then analyzes the oocytes for their quality and their maturation. So sometimes the smaller eggs which we retrieve after the pickup might be immature or not be grown as much. So in this scenario, the embryologist, they mature these eggs outside the body, so which is known as in vitro maturation or IVM. So in certain patients, if in spite of the injections or no matter what the duration or dose of therapy, we sometimes retrieve some eggs which have not attained their final maturation inside the body of the patient. So if such number of immature follicles or immature eggs is higher, then those eggs can definitely be subjected to IVM, which will yield us a mature egg, which can definitely add up to the numbers of mature eggs and yield us to a better embryo quality. So this is also one of the things which is advanced, and this is definitely in the hands of the clinicians and the embryologists. So another thing that is to be considered here is when the age is advanced or when the ovarian reserve has fallen, even if it is in a lesser age, like if the lady is younger but still the ovarian reserve is less, there is a higher suspicion of some genetic issues that might be hidden or that might not have been diagnosed yet. So there has to be a genetic testing of the embryos, which we know as PGTA or PGTM, in which there is, before we choose the embryos for their transfer, we subject them to their genetic testing and analysis, which gives us results in the form of whether the particular embryo is genetically normal and will give rise to a healthy and chromosomally normal pregnancy or not. Only such embryos will be then chosen for the embryo transfer, which makes sure that the growing baby does not have any chances of getting any genetic conditions which might be transmissible from the parents. So, such embryos which we derive when treatment is done in cases of low ovarian reserve should definitely be offered the option of PGTA. So, that is also another thing to be considered. Of course, in spite of all of this, there are a few patients in which a double stimulation or a pooling cycle might also be required, because a single cycle of stimulation might yield us uh, an embryo or two. But if we want to subject them to PGTA, or if we want fewer more options for a healthier or better quality embryo to be made available for transfer, then in this scenario with a falling ovarian reserve, it is definitely a prudent advice to undergo another set of stimulation with some modalities that have not been done before, and a pooling of oocytes to be done, in which we desire to get better yield of embryos, which are then available as an option for the embryo transfer, so that the best embryos are then selected for the first embryo transfer, and we can achieve a better pregnancy rate or a better success rate. In this scenario, there is one more thing that can be done at the time of embryo transfer, which is laser assisted hatching of the embryos before we take them for the embryo transfer. So there is a coating which is surrounding the embryos, which we call as the zona. So the zona pellucida, sometimes due to freezing or due to advanced maternal age or due to poor quality oocytes, might be thicker in some patients. So such embryos find it hard to break that zona or hatch that zona on their own, and does require an assistance from outside, which we can grant by the use of laser. So laser assisted hatching of this zona enables the embryos to hatch the zona effectively and get implanted to the endometrium, which indirectly is going to give us a higher implantation rate and a higher success rate. So of course, going the extra mile for low ovarian reserve or diminished ovarian reserve requires a combined or a team effort from almost 3 to 4 fronts. That is, the first front is going to be the clinician who is going to chalk out your plan, who is going to determine how much time can we dedicate to simpler treatments, or do we need to move on to higher treatment immediately, along with some extra treatments which are non-conventional, what kind of protocol to be used for your particular case, along with another pillar which is the embryologists. The embryologists are going to help in the laser assisted hatching of the embryos, the pre-genetic testing and analysis of the embryos, and the IVM is something that can be dealt with by the embryologist, the geneticist, which form the third pillar, and they are going to suggest which are the genetically normal embryos which should be used primarily for the embryo transfer. The last and the most important pillar of this support system is the patient themselves, which is the lady herself, because it is up to a certain extent on her level also what kind of diet and lifestyle she maintains and what quality of oocytes are we going to get. Of course, all these things are definitely going to need awareness on your part. So that is the objective of today's Facebook Live. And I'll end this session with this note and this take home message today. If there are any questions, I would be happy to answer them. So there's a question, how to fix low ovarian reserve. So ovarian reserve is something that is not in the clinician's or the patient's hand per se, but definitely, as we discussed, like there is no particular way in which you can increase your ovarian reserve, but definitely how to maintain the quality and how to get a better quality egg, even if the number or the quantity is less, is something that is in our hands to certain extent. So that you can achieve by uh, opting for a healthier diet, for changing your lifestyle habits, whichever might be detrimental to the oocyte quality, and to approach your clinician to have some awareness about these fertility treatments so that if you are facing some challenges in your reproduction or conceiving, then you know when to approach a specialist and what are the options when you approach. So any further queries, or if you want any consultations regarding low ovarian reserve, feel free to contact on Oasis Fertility helpline number mentioned below in your screens. Thank you.